Struggling with NCLEX questions even after memorizing ADPIE? You're not alone. Memorizing the nursing process is a good start, but understanding and applying it clinically is where most students struggle. As a nurse educator since 2012, I've watched countless students memorize the steps and still struggle when it comes to applying them on NCLEX-style questions. The nursing process isn't just 5 steps to recite. It's a clinical reasoning tool that, when you use it incorrectly, NCLEX will definitely expose that fast. In this video, we're going to break down the nursing process step by step using real clinical examples so you can stop memorizing and start reasoning like a nurse. We're going to begin with the definition of the nursing process and dive right into each step. Let's begin.
What is the nursing process again?
The way in which you provide patient-centered care.
Okay. What's another definition of the nursing process?
How you care for an individual as a whole.
Okay, there's this keyword I'm looking for.
Nursing process and the steps of...
There you go. That's all I wanted. The steps. It's the steps or the systems or the method in which you provide quality care. Now, give me those steps to the nursing process. Okay, I know you like the pie. Thank you. ADPIE. Yeah. What's the steps?
Okay, assessment.
Diagnosis.
Planning. Implementation. And then evaluation.
Don't play with me. So the very first step in anything that you do related to providing quality patient care is what? Assess. What does it mean to assess?
It's when you collect subjective and objective data.
Go give her a sticker. When you collect, it's just data collection. And she said subjective versus objective data. Beautiful. What does it mean, subjective?
Subjective?
Like
What the patient is telling me.
Okay, give me an example of subjective data.
Pain level.
Very good. All right, give me another subjective example.
like having a stomach ache or something like that.
Okay, that's the same thing. Pain. Yeah. Give me another one.
Coughing.
Nope. What is subjective again?
What the
The
patient
patient tells you.
Okay, what the patient tells you. So give me something, a data that the patient is describing, but you cannot see as a nurse. But the patient is complaining of this thing. We already got pain, or stomach pain, same enchilada. What's another thing?
Fever.
vitals.
No. Fever. This is how you know they have a fever.
I feel like they're feeling hot or something.
Okay. No, because who could know? Because that's data that you're collecting.
Feeling dizzy.
Feeling dizzy. There you go. Nausea. Okay. Feeling or the vertical, because you can't see it. This is data that you yourself as a nurse are unable to objectively see. Does that make sense? This is what the patient complains of. They may complain of feeling hot. If they complain of feeling hot, but yet you can go in and take the temperature. That's objective. So objective data then is what? What you can measure as a nurse. Okay, what you can see, temperature, vital signs, that's objective data. Okay, seeing that the wound is 10 centimeters wide and 11 centimeters long is what? Objective or subjective? Objective.
So I have a question back. So a question in PEPU, I think, or somewhere that was talking about putting what the patient says in quotations. Does putting it in quotations change the type of data, or is it still subjective data even though we're quoting it?
So you're putting it in quotation marks what the patient is saying, like I feel nauseous. And you put it in quotation mark, that is subjective data. Okay.
And what's the purpose of putting something that they say
This
in
is
quotation?
okay, that's for documentation purposes, to be as accurate in your documentation as possible.
Okay.
All right. Are we clear on subjective versus objective data? We sure? Okay, let me see if we're sure about
I
that.
still got one more question.
Okay.
Okay, so talking about patient history, we're asking questions and the patient is giving us like their medical history. So they tell us that they have a diagnosis of XYZ. Is that considered subjective?
No. Now this is now the source of the data.
Okay.
And there's two types of sources of data, which we may as well just go on into it since you brought it up. Two types of sources, which you must know for NCLEX purposes, because after that, you know. The types of sources is primary source, secondary source.
Okay.
Primary source of data is coming from the patient. Your patient is always going to be your primary source of data. Patient. Now, secondary is going to be from anybody else or anything else. Medical records, families, the nurse's notes or whatever. All of that is secondary source of data. Are we clear? Now, let's say, here's where it's going to be a little bit tricky, okay? Let's say the patient is comatose or is unable to express themselves for whatever reason, okay? There's a variety of reasons. Either they're in a coma. Now, the family member who was there when the incident took place, they now become the primary source of data because they have a first-hand account of the event.
Wait, you said they become primary?
They become primary source of data.
When the patient.
When the patient can no longer, for whatever reason, provide that information because they have a first-hand account. Anyone that provides a first-hand account of the situation, they become, apart from the patient, is the primary source of data. But typically, the patient is always the primary source of data.
Like a child, since they're in the care of a parent, that would be their primary, because they're the primary.
Not quite. So it got to be very specific. If it's a child that is able to speak,
Then it's.
we're going to talk to that child.
But if they're in, incapacitated.
Like a newborn baby. Let's take a newborn baby.
And the parent would be. But
Yes.
then if it's a child that can engage.
That can engage, the child will become the primary source of data.
And then the parents, even though they're the legal guardian, they would still be.
Because it's not about legalities or anything like that. It's just about a source of information.
So they would be secondary and the child would be primary.
Yes. Okay, cool.
What about if the child was like paraplegic and they couldn't speak but they could like still interact? They would still be primary?
They will still be primary. Let's take it a step further. Let's say you have a patient, a child who is like either Down syndrome, okay, or who has some neurologic deficit or autistic on the extreme end of the spectrum, right? You can still gather data from that child.
So they still be primary?
They will still be primary. Now, because they're going to give you signs or some indication that tells you that they are in pain or they are uncomfortable. Either they make noise, either they make some type of movement, or they're guarding that area. That's still the primary source of data, okay? But let's say you need something specific for like you notice like there's bleeding and they are unable to explain why are they bleeding from that extremity, or why they're bleeding, why is blood coming out of that body. You may have to rely on now either the legal guardian or family member or whomever was there when the event took place. Now they are able to provide first-hand account of the situation, so now they become a primary source of data for that person who or patient who is unable to explain it.
So I have another question.
Sure.
If there is no, same scenario, but like there's no parent or guardian there for that child or patient, and they get a cut, or like you said, and we're the only ones there, they didn't notice they have it or they're bleeding, but we see it. Would we then be the...
It's on their body.
Right.
You're documenting. This is you assessing.
Okay.
That's your assessment.
So they would just be...
It's because you're still getting the information from where? Them. Okay? Not just because you witnessed it before they witnessed it or whatever, or was able to identify, because that does happen. There are patients who were still awake, alert, and oriented, and let's say they had diabetic neuropathy. They didn't even notice that their foot was cut off because they wasn't paying attention, but you noticed it first. That doesn't make you the primary source of data.
So it would just be primary or just assessing?
You're assessing, but they are still the primary source of
So it'd
data.
be like primary source of your assessment.
Yes. So source is simply where did you get the information from in the first place? Primary source of data, we always are relying on the patient, no matter the situation, for the most part. Okay? And everybody else, everything else is secondary. Cool? All right. Now, I want to make sure, let me see. The patient is having an unsteady gait. Subjective or objective data? Because I was able to, okay. The patient complains of pain level 20 out of 10. Subjective or objective?
Subjective.
With regards to the nursing process, you must know that the nursing process is not linear, it is cyclical, it is ongoing. So in other words, you start with your assessment and you end up your evaluation and you find yourself going back to assessing again. Okay? Let's say, for example, you did your assessment, you went through the whole process and you did your evaluation. Now your evaluation is what again?
Checking to see if it works.
Checking, yes. Now remember, evaluation, you don't confuse this because it's coming up in an exam some way, shape, or form. Evaluation is a form of assessment.
It's a reassessment.
Thank you. Okay? But this is a type of assessment that is simply identifying whether your plan and treatment worked or did not work. Did you meet your goals or did you not meet your goals? Okay? And then if you did not meet your goals, you know what you're going to do? You're going to go back to the drawing board again and then be like, okay, then let me change this and start assessing all over again and all the way to the end. Are we cool on that? Don't play with me. All right, I'm going to see if we're cool. How do we collect the data? Okay, there's different methods you have to be familiar with, even as a nursing student and a registered nurse. We nurses, it becomes secondhand that we don't realize that we're doing this. But there's different ways in which you are collecting information or collecting data. Observation. Least invasive method. Okay, inspection. I'm just looking at you. Oh, okay. Your hair looking on point today. Oh, okay. Yeah. Well, can't I? Boom. I'm just simply observing you. That's it. All right. And then we'll do interviews. Another method is to just interview the patient. All right. Engage in a conversation. And this goes into your communication. We talked about this. So type of communication techniques that you're going to apply. Let's now take it back a bit. Give me a communication technique.
Open-ended question.
Thank you. What's the benefit of open-ended question?
It allows the patient to keep talking.
To keep talking. Okay. Give me another one. What is closed-ended?
Just a yes or no response.
Just a yes or no. What is there any benefit to a closed-ended question?
Yes, if you're trying to get a direct answer.
Okay, she ain't fall for it. All right. Give me another communication technique. We got open. We got closed.
Therapeutic.
Okay, all this is therapeutic communication. What? Give me another type of technique for therapeutic communication.
A clarifying question.
Oh, give me clarification. What does that mean?
Like if you're unsure of what a patient said, you don't want to assume to ask a follow-up.
Okay, you see all those different types of communication techniques. You do them all during the interview process. When you try to get in all into their business, in other words, trying to find out why are you here in the first place, okay? So you're engaging in the conversation. Now, another method that we collect data is by doing an actual physical exam. We do an actual physical exam by doing maybe either a head to toe, or we do or a focus assessment, which we'll talk about. But that physical exam requires us to look or observe, in other words, inspect the patient. Then we go palpating, all right? We percuss, and then we also auscultate. Auscultation means what again? Listening. Okay, and we'll talk about these different methods in a little bit. Another method in which we collect data is review of records, where we basically, okay, we need more information, and we're probably going to get some of that information or specific information by looking at your medical history. We're probably going to see what medications you're on or you've been on in the past, looking at previous lab results, previous vital signs, looking at the history to see what were you like before, what the changes are, etc. And then I give an example, okay, of these data collection. Next. All right, I talked about the primary and secondary sources, okay? And I give an example. Let's go next. Now, the different types of nursing assessment, because yes, it will come up on the exam in some way, shape, or form. You have an initial assessment. That's pretty much self-explanatory, right? Initial assessment is, your first time encountering the patient, and we just gonna go into collecting data, all right? That happens in the beginning, all right? Then we have a focused assessment. Now, this is where I need y'all to pay attention, okay? Because this might come up on NCLEX, maybe, all right? Focus assessment is when you are targeting a specific issue. We're not doing a complete head to toe. Maybe it's because there's a priority, okay? But we're just focusing on one particular area. For example, the client comes into the ER complaining of an abdominal pain. So what is our focus assessment going to be on? That's GI, the abdominal pain. We're not going to look at your gangrenous toe that's falling off. We're not going to look at deal with the headache you're complaining on. We're just going to be focused on the abdominal issue. Does that make sense? Okay? Then you have a quick priority assessment. This is where now you are focused on the critical points related to this patient's condition. Okay? So let's say, for example, the patient does come in complaining of nausea, but yet you notice that, hey, your blood pressure is like 200 over 150. Yeah, we're gonna have to deal with that first. Or you may be complaining of nausea, but yet also chest pain, and maybe you are maybe you have a an MI. So we probably are going to have to address that. We're going to prioritize your care. So a quick priority assessment where you're focused on the critical health issues serves as a flag to say like, hey, we got to deal with this right away. Okay. Emergency assessment is performed during a crisis to identify life-threatening issues, okay? Now, this is not, again, it's kind of similar to QPA. However, this is focused on the immediate needs. This is when you're prioritizing, again, according to like Maslow's hierarchy of needs, for example, airway, breathing, and circulation. Like, this is an emergency. We have to deal with it right now, okay? That's the emergency. Especially when it's mostly used in situations like where ABCs is compromised. Okay? Are we cool? Okay? The difference between emergency and QPA is like focused on the critical problems, whatever that may be. Emergency is focusing a lot more on like, yeah, your airway is being compromised, breathing is compromised, circulation, those kind of things. Okay? Your physiological needs are in detriment. All right? Then you have another type of assessment, which is time-lapse assessment. This is where you're comparing data from the beginning of time. Now, when I say beginning of time, I don't mean like ancient years, okay? I'm talking about beginning when you first met with the patient, and then how you continue to monitor that patient's ongoing discharge, right? You're monitoring their progress, in other words. That's time-lapse, okay? I gave an example where you're reassessing a patient in a long-term care facility. Another example may be you are being treated by a primary care physician, and they're having you come in every 3 months or every 6 months. That's time lapse. Okay, so we're seeing where you are, how you're doing in the beginning, and we continue to monitor your progress throughout. Okay, up until our relationship ends. All right. Triage. What is triage?
we're figuring out what parts of the condition need to take priority and then figuring out the order to address each individual thing.
And notice what we're doing. We're screening you. Okay? So I got Alia here as my patient in the ER. Y'all coming to me for help in this cold Florida winter day. Alright? Some of y'all can't, some of y'all acting like y'all can't walk, and some of y'all, doing this, that, and the third. So I am going to triage for the sake of my own sanity as a ER nurse to see who needs to be seen first, who can wait a little bit, and who could just go to their primary care doctor. That's triaging. I'm screening. It's almost like sifting. You know how when you sift wheat, y'all know about sifting wheat, no? Okay? I'm sifting to see, okay, who should be here, who needs to be seen right away, who can wait a little bit, and who can just go to their primary doctor. That's triage, okay? And then you have PCAM, which is patient-centered assessment method. I know it's not talked about a lot, but it is in your book, so I mentioned it. This basically evaluates patients' complexity of care, all right? And you're also, the other thing with regards to PCAM, which is patient-centered, you're also seeing what are the factors that prevents the patient from adhering, okay, to regimen. Is there social determinant issues? Is there a lack of education or understanding, okay? It's all focused on the patient and their care. That's why it says patient-centered assessment method, okay? So an example is discussing the patient's living situation, support systems, and healthcare literacy, etc. That's an example of PCAM. It's all about the patient and their needs and their understanding. Are we cool? Now, the other one is a complete head-to-toe assessment, where you go and you just basically doing that. You're assessing the patient from the tippy tip of their hair down to their toenails. Okay, to make sure that everything is going well. Now, you have all these different types of assessments. You're not going to always use all these different types of assessment. It depends on the situation presented before you. If I'm going to the doctor's office for a yearly checkup, what type of assessment would be done? Say it louder. A full head-to-toe assessment. Okay? I go to the ER. My stomach is killing me. I'm dying. Okay, let's go see what's going on. Okay, take a chill pill. All right. It's not that serious. You're not dying. Calm down. Let me look at your stomach. And she starts touching and probing and doing. What type of assessment did she just do? Focus assessment. Okay. Does that make sense? Okay, boom. Comes in. She's doing a home health check. Okay, she's a home health nurse. And then she goes in and like, oh, I noticed you didn't fill your prescription today. What's going on? What happened? And the patient starts explaining their whole life situation, and she starts educating them. This is why you need to be more adherent. What type of assessment did she conduct?
Patient-centered.
You see? Well, don't play with me during this exam, okay? Okay, the assessment process, I already talked about that. Don't play with me. Next. Okay, during the assessment, we already did this, but I gotta talk about it just in case y'all have amnesia. You gotta consider several factors, right? Cultural sensitivity. You already know cultural competent care, okay? When we learned about this already, if you are not familiar with the patient's culture, the patient comes from culture X, I know nothing about culture X, what am I going to do? Say it louder. Educate who?
Ourselves.
Yes, okay? All right, let's say the patient who comes from culture Z. He can't stand people from culture Z. What is he going to do?
Eliminate biases.
Say it louder, please.
Eliminate biases.
He's going to address the fact that he does have this bias, and he's going to eliminate that bias. Okay? Boom. That's part of cultural sensitivity. We're all talking about taking care of the patient, no matter their culture, background, social demographics, etc. You always must remember to provide patient privacy. So you come in, you either close the door or you pull the curtains, etc., all for the purpose of maintaining confidentiality, respect, and dignity, all right? Because we ain't trying to have the patient's business all out there. That ain't cool. And then, of course, we're going to utilize clinical judgment. This is where a lot of students fell short. Utilize critical thinking just so you can see what data that has been collected, that needs to be collected, and how it relates to the situation that you're dealing with now. And let me be specific, the health situation that you're dealing with now. That's the purpose of clinical judgment. You gotta exercise critical thinking. And the data that you collect is going to guide your critical thinking. And there's data, if you fail to collect certain data, it's going to mess up the patient care that you provide. That's why you got to pay attention to everything. You have to be very observant. That's why the very first thing you do as a nurse who shows competency, let's say it like that, the first thing you do is you are observing the situation before you. You don't freak out, okay? You observe, okay? Sometimes it may call for a quick observation. Now, must take time with this, because this y'all be tripping on. Okay? It better not be y'all too. Diagnosis. What did we say was diagnosis?
Identifying the disease.
Say it louder, please.
Identifying the disease.
Not identifying the disease.
The patient's symptoms, kind of.
Problem. Identifying the problem. You're putting a name to the problem. You collected all the information you needed to. Now, based on all this information, now I'm going to put a name to the problem. I'm identifying what the issue is. Be careful, you never ever identify the disease. Who identifies the disease? The doctor. Are we doctors? No. But what do we do instead? We identify how the patient responds to that disease. Okay? We identify how they respond to it, and we treat according to how they respond, how the body responds. In other words, the doctor deals with the disease, the nurse deals with the illness. Two different things. Make sure y'all know this. The doctor deals with what?
The disease.
The nurse deals with the illness, okay? The doctor or the nurse practitioner or the physician assistant, they are the one dealing with the disease. Registered nurses are LPNs, illness. Now, when we put a name to the problem, number one, you must know in your diagnosis, in your nursing diagnosis, if it's not collected in your assessment phase, it cannot be a part of your problem or your problem identification. Explanation, of course, it involves analyzing the assessment, and you look for patterns in the data that you collected. Okay, for example, the patient has acute pain, risk for infection, etc. So, the diagnosis, what you have to understand is, you can't say anything, you can't say it any old way, in other words. You're going to use the Nursing Diagnosis Handbook, which serves like our language Bible, so to speak, of how we communicate what we've identified. Looking for patterns, and you notice the patient says, when you collected the data, the patient says that they are currently experiencing pain at a level of 9 out of 10. So that was your assessment. So your nursing diagnosis is going to be something like acute pain. That is the problem, okay? Now, there's 3 types of nursing diagnosis. You have no problem at all, which we're always happy when we have no problem. Those are your health promotion type nursing diagnosis, where there's no issue and the patient just shows readiness to learn. Okay, health promotion. That's one type of nursing diagnosis. Now, another type of nursing diagnosis is when there is a risk for that problem to exist. That's called your risk for, okay? That's what it says, possible problems. That's your risk for, okay? Your third type of nursing diagnosis is when you actually have the problem. The problem actually exists, so it's called actual nursing diagnosis or whatnot, okay? So I talked about them, health promotion, your problem focus, and your risk. You must know these 3, okay? If the patient doesn't have any type of problem again, what type of nursing diagnosis are we using? Health promotion. Now, the patient doesn't have the problem, but they show that they are at risk of having or developing that problem. What is that? Risk for, okay? And they actually have the problem. What is that? Actual or problem-focused nursing diagnosis. Let's make it make sense. It comes in the room, it finds me going like this.
You're drunk?
Okay, not drunk. She said I'm drunk. First of all, what's my assessment going to say about my walk? Unsteady gait. My gait is just unsteady, so that is what he's going to put on his assessment. Unsteady gait. Now, because of the unsteady gait, what type of nursing diagnosis would I use? Huh? What is that type called? What type of nursing diagnosis is that?
Objective?
No.
Oh.
Not actual.
Risk.
Your risk. This is your risk nursing diagnosis. Did I actually fall? No, but I'm at risk for falling, so I'm going to use a risk nursing diagnosis. So your nursing diagnosis is going to say risk for fall. That is the problem. Your first part, and I know it's going to come up, but I feel like saying it right now. Your nursing diagnosis has 2 to 3 parts. The third part of the nursing diagnosis is usually optional, but when you go and do your clinicals, you know what I'm saying? You want to show off and make your clinical instructor happy, use a third part. Use a third part. The first part of the nursing diagnosis is going to be your problem. Risk for fall, right? The second part of the nursing diagnosis is going to be your etiology. The cause. And it's usually followed by a related to. You must always have these 2 parts in your nursing diagnosis. No question asked. Always have at least these 2. The third part, which is usually optional, is going to be your sign and symptom, I call it, okay? What is the evidence that shows that the patient has this problem in the first place? And you usually see it as followed by as evidenced by. The more you put correctly, the more you correctly put in terms of your nursing diagnosis, or the more specific, let me not say the more you put, the more specific you are in your nursing diagnosis, the better it is. So, his assessment, you notice, risk of unsteady gait, right? So because of the unsteady gait, the problem now becomes risk for fall related to the unsteady gait. The related to, or the etiology, is going to come from your assessment. It has to, and if it's not in your assessment, it's not in your nursing diagnosis. Okay? So related to unsteady gait. That's really enough, right? Yes.
I'm confused. So the unsteady gait is the cause, not the problem?
It's not the problem.
It's
the cause. Yes.
Or the person's at risk?
Yes.
So then what's the problem?
The risk for fall is the problem.
Is the problem.
Is the problem.
Oh, okay.
The cause of the problem is because I had this unsteady gait.
Right.
So know the 3 types. For testing purposes, you just need to know the 3 types. Okay, so this is where, again, the etiology and the signs and symptom portion, they come from your assessment. Let me stress this again. The etiology and your signs and symptoms, everything comes from your assessment, but these are your proof that this is the issue. Does that make sense? So and you have your proof in your assessment, okay, of incorrect nursing diagnosis. Patient is in pain. You do not write patient is in pain, okay? Another thing, because it's not specific enough, right? So instead you would put acute pain related to what's the cause of the pain, the surgical incision. Now, If surgical incision is not in your assessment, you cannot put it as you're related to. So your assessment has to show where you assess for a surgical incision, where it's located. So you noted a surgical incision in the left lower extremity, in the size, etc. Okay? If it's not in your assessment, it is not a part of your nursing diagnosis because you don't have the evidence or the proof for it. Are we cool? Patient has diabetes. What's wrong with patient has diabetes?
That's a doctor.
That's a, you see, don't play with me. Because I'm going to slip some of those things in there in that question. All right? And you have to be like, oh, she ain't going to get me on this exam. We do not say patient has diabetes because it's a medical diagnosis. Instead of the diabetes, we're going to say how they're responding to the diabetes. Patient is at risk for unstable blood glucose levels. Yeah, because that's what's happening. And why are they at risk for unstable glucose? Because they lack knowledge of how to make, okay? Again, this part has to be where? In your assessment. If it's not in your assessment, it's not in your nursing diagnosis. I cannot stress this enough. And then, of course, again, as evidenced by patients verbalizing confusion about carb counting. Or you can even put this in parentheses as evidenced by patients verbalizing, in quote, I don't understand what's going on. You could put that in your nursing diagnosis. However, it has to be where again? In your assessment. I'm stressing this because I know some students, not y'all, be hard-headed. Don't play with me. You see I'm taking my time? Don't play with me. Okay? Or risk for diabetes. No. What's another example? Oh, patient at risk for CHF. Bruh, we're not medical doctors. Chest pain. Now, I can say chest pain. That's not a medical diagnosis. Okay?
Could you also say like evidence by excessive intake, like amounts, like eating, causing their blood glucose to rise?
Yeah. So again, that has to be in your assessment. Patient consuming donuts and Mickey D's and Starbucks. I don't know. And you can say as evidenced by patient consumption of hamburgers and fries or whatever. Yes.
And so like you would put that in your assessment because the patient told you this is what I eat, this is my.
Whether they told you this was what you ate, whether that would be subjective because they told you and you didn't see it, or whether you actually saw it, but it's in your assessment data. Okay?
So it can have objective data?
Yeah! In your nursing diagnosis? Yes!
You can put like as evidenced by like hemoglobin A1C.
Yes! You can definitely say that because that's your data collection. Again, it has to be in your assessment. You interpret the data, looking for patterns, and you're also looking for significant problems as it relates to the pattern and the patient's condition as well. Okay, so I give an example. If a patient has a high blood pressure and reports feeling anxious, the nurse consider how these two factors are connected. In other words, you're collecting a multitude of data, and you notice that some of these, they have a connection. For example, the patient is complaining of pain in the epigastric area, 7 out of 10, all right? And your data also reveals an EKG result of a STEMI. Those two relate. Does that make, because they maybe have a heart attack. Maybe he's hurt. You understand what I mean? So you can see how data connect to each other, all right? You identify the health issue, and then you come up with your nursing diagnosis. Now, I know it says here that nursing diagnoses are standardized statements. Sometimes you may find yourself having to adjust your statement specific for that patient's issue. It's just serving as a guide as how we can actually come up with our nursing diagnosis or put it into a verbiage that every nurse would understand. Okay? The process of how you actually come up with your nursing diagnosis. Of course, after you collected your data, you're going to review the information that you just collected and then identify those issues. Look for patterns, right? Especially as it's specific to the process, to the patient's issue, and you are going to prioritize. This is where I want to stop. Let me tell you something, guys. You come up with an assessment, you can come up with 1,000 or even 1,000,000 nursing diagnoses. There's no limit to the amount of nursing diagnoses that you come up with. However, you need to be able to prioritize those nursing diagnoses. That's very important. That's very important, not only for test purposes, but also when you become that nurse. Okay, you're gonna have to prioritize your care. Now, some of these, you're gonna be so good at doing the nursing process that you're gonna actually take care of it right away, like without doing your documentation, okay? But you prioritize your care. For example, you see the patient turning blue, but they're also complaining of nausea. Which one am I turning blue? Risk for the patient is inadequate oxygenation versus nausea. Which one I'm going to deal with first? Oxygen. The oxygen. So you prioritize accordingly, right? And then of course you're going to formulate your nursing diagnosis. This is part of critical thinking, and you use it to make connections between the pieces. You're like putting pieces of the puzzle together. That's all a part of critical thinking. And based on the pieces of the puzzle that you put together, you're starting to now draw a conclusion, okay? You're collaborating. You gotta know, nursing or healthcare, I should say, let me say healthcare, is not a one-man show. We can't do it all on our own. We gotta deal with other healthcare providers as well. So we're collaborating with the physician. We're collaborating with our tech. We're collaborating with respiratory therapists. We're collaborating with OT. We're collaborating with PT. Anybody who needs to be on the patient's case to make that patient feel better, we're collaborating with them. And collaboration involves effective communication. That IS bar that we talked about last week, this is where you're definitely going to be using your IS bar to collaborate effectively with the different disciplines, okay? Because you need to know what to say. Certain things, like the doctor don't need to know you was bathing in C. diff. You know what I mean? That's not important to them. The physician should know that the patient had 11 loose stools within 2 hours. And then you have patient involvement. This is where you engage the patient. Is it important to even involve the patient in the first place? Yes or no?
Yes.
It's my nursing diagnosis. Why should I involve the patient?
Make sure.
Patient-centered autonomy.
Autonomy, and what else?
You need to make sure they like comply and like are able to.
To improve adherence, okay. Make sure that they comply. Okay, I don't want to say make sure that they comply because remember they have the right to refuse, but it does improve adherence or compliance. What else is another reason I'm involving the patient?
It can also be more accurate.
Say it again.
It can also be more accurate.
Elaborate just a little bit more. What you mean it could also be more accurate?
Because during that time, you can also clarify if the symptoms that you heard is correct.
But yes, very good.
Subjective data,
Okay, what about the subjective data?
like your assessment, or what they're complaining of, their problem.
Okay, because you need to know who's the information gonna come from anyway. The patient. So your nursing diagnosis, you gotta get the patient involved. Why am I stressing this? Because when y'all pass nursing school, you pass NCLEX, and as soon as we get into the field, we forget this one important piece, the patient. I see a lot of my colleagues, nurses, like experienced nurses, is like, I just need to get this work done, forget the patient, keep it moving. It happens, okay? You do want to get the patient involved. And also it keeps everybody on the same page of why the patient is here in the first place and what's the goal, what's the outcome that we're looking for. So I give you some examples of the nursing diagnosis. I give you a scenario here. The nurse is analyzing a patient's data after the assessment for heart failure symptoms. So she collected these data and notes that the weight has increased blood pressure, and the patient is complaining of shortness of breath. This is the data that she's collecting and that she collected and reviewed. The nurse is identifying some problems, right? Or patterns. She noticed that, okay, based on what I'm noticing, the patient does have a combination of weight gain and shortness of breath. Those two pieces alone indicates that, A, the patient is probably suffering from fluid retention. Because why are you gaining weight all of a sudden and you're short of breath? So the patient is retaining fluid. That's what it suggests. Okay? So now, based on this, and again, this is a suggestion. You see how I was clear to say that? Because it doesn't automatically mean that I have to now validate that, okay? And I'll talk about that in a little bit. Then you prioritize your care. So you say fluid volume excess, okay, is a high priority diagnosis because this patient, if we don't get rid of that fluid, once we've identified that they have fluid, they could go 6 feet under pretty soon, okay? And this is the nursing diagnosis I come up with. Excess fluid volume related to compromised regulatory mechanism. That's just sounding all fancy, okay? That's just basically saying that they can't breathe, okay? As evidenced by, see, weight gain of 5 pounds in 1 week. Again, that 1 week, 5 pounds in 1 week has to be in my nursing assessment. If I didn't say it in my nursing assessment, I can't put it in my nursing diagnosis. And shortness of breath. Okay, now you see how I put all of these here? I could also choose to separate it if I want to. Make one for 5 pounds and make another one as evidence for shortness of breath. You can do that, but it's not a problem if you combine them as well. All right?
I have a question.
Yes.
Okay. So say we did our assessment, we're starting our nursing plan, going through the nursing process and stuff like that, and we realize we're missing some key information to finish the plan.
Go back.
We go back and we start over.
You don't.
Or do we just go back and clarify?
And clarify. There you go. Clarify that data. And it happens many a time as nurses. We like, oh, how do I know this? I didn't even get this information. I can always go back and gather that. I must go back and gather that information, especially if it's pertinent for care. Okay, yes. It doesn't mean you have to start all over again. You just go and collect that data so you can move forward. Okay, good question. Now, what did I stress before I move on to planning? When you are formulating your nursing diagnosis, number 1, 3 parts. Your problem has to exist. And again, the problem is what the issue is, what the issue you identify. You're related to is the etiology. What's the cause of the problem? So remember, the cause, the unsteady gait is not the problem. You cannot put, in other words, unsteady gait related to fall or risk for fall. That's another thing I've seen students do. You can't do that. You flip the script. Does that make sense? This is wrong. Instead, you're gonna put risk for fall related to the unsteady gait. We're cool? All right, let's go. Planning. This is now the next step where you're gonna try to come up with interventions or and ideas of how you're going to deal with your issue. With regards to planning, this is where you're going to come up with ideas of how you're going to deal with the problem that you even identified. The planning portion, this is where you're going to set goals. And your goals have to be SMART. You ever heard of that? SMART? What is SMART? Specific. Measurable. Attainable or achievable. Same enchilada.
Relevant.
We're gonna see relevant, relatable. What's another R that they put?
Realistic.
Or realistic. Thank you. Realistic.
And then time.
If you're missing one, even at least one of these elements, your plan is inaccurate or incomplete. You have to have all of these measures or factors in place for your plan to be complete, all right? Okay. Now, with regards to the planning, okay, you gotta understand that there's 3 types. In other words, you have the initial plan, which usually is done on your first encounter with either the patient or the situation, and you're addressing all the problems that you even listed. And it could be ongoing, where the nurse continues to keep up with the patient and monitor their progress, looking for risk factors and stuff like that. And then it's also the discharge planning, which is usually carried out when the nurse is getting ready to end the relationship. And now discharge planning, I have to back up and say, discharge planning is usually done once the patient is admitted. As soon as the patient comes into the facility, we are starting on your discharge plan to make sure you have everything that you need when you are leaving, okay? Because once we start once you come in, we have to make sure, number one, let's say for example you need medication, IV medication, or an O2 tank. We're not going to wait to the day of discharge to start planning for you to have those things. Does that make sense? Soon as we've identified that that's a need, especially on admission, we're going to be working on that. That helps reduce the length of stay. That also helps with the transition to the new setting. Okay, so discharge planning is usually done in the beginning. All right. Okay, so you're prioritizing. You see, there's a reason why I put all those things, Maslow's hierarchy of needs, in the beginning, because these are things that you're going to utilize when you are going to prioritize the patient's care. You can utilize Maslow's hierarchy of needs. You can utilize airway, breathing, and circulation, for example, when prioritizing care. Also, you can use the patient's preference. Please, guys, the patient is the reason why you even have a job in the first place. You want to include their preference. Does that make sense? All right, what is it that we need to do, okay? The other main reason, not because you need a job, but the main reason, the patient's been with their body their whole life. So they know themselves, okay? Maybe they might need some education, that's true, but you want to know what is it that you want. Some patients, believe it or not, are not there to be treated. They just want to know what's wrong with me. And that's cool. All right, we're going to work on that. Let's find out what's going on with you. And then they will try, some of them, they just want to know what's wrong with them, and they know so that they outside of the facility, they could take care of it themselves. That's okay. And then also it helps with anticipating future problems so we can prevent them as much as possible. Time, please, people. Time is not limited to by 8 o'clock in the morning, like a specific clock time. Which you can use, by the way. The time can also be before, at the end of shift, or within 4 hours of nursing intervention, or by discharge. All of those are time bound. You're putting a limit to when you want to see this thing actually being accomplished. Now, when you put the time bound, it got to be realistic. Let's say, for example, the patient who's been a chronic smoker for 40 years. It's not realistic to say patient will stop smoking within 2 hours of nursing intervention. That's not realistic. When it comes to planning, you have to know your short term, which is less than a week, and you're going to need this for when you do your care plan. And then you have your long-term goal, which is usually by discharge, but at least more than a week out, okay, of when you did that intervention. For example, the patient will be able to demonstrate understanding of medication regimen within 2 weeks of nursing intervention. That's long term, and that's realistic. Then after planning, you got your action. Okay, you just put it into action. When you are going next, when you are doing your implementation during your care plan, you're going to put the rationale. For your care plans, you have to put the rationale as to why you're doing this intervention. What's the point? What's the benefit of implementing this strategy? Okay. But in generally speaking, this is your action phase, and you're executing what you planned, right? For example, in the implementation, you see that the nurse actually administers the pain medication to the patient. In your care plan, you're going to put, your rationale and your source of your of where you got that rationale from, and that's your nursing handbook. The Fun Nursing Diagnosis Handbook. All right?
I just have a question. So, with a nursing diagnosis, in the field, you don't really use the book. Is it, I think it's generated?
Yeah, it's already pre-generated. Like how we're going to use DocuCare?
Yes.
Now, it depends on the facility that you work in. If you go out in a rural area, most likely you'll have to rely on these, okay? So it depends on the setting. Also, it depends. When I say setting, it doesn't even have to be rural, but some facilities, maybe I'm assuming nursing home. I could be wrong. Don't quote me, but it's not every facility that has pre-existing care plans that you just choose from. They might have to. You actually might see they're writing it on paper. Okay. All right. The nursing intervention classification, this is how it's basically, your interventions are classified. They give you examples. Now, the main thing that you should know is that with nursing interventions being classified, they can be classified under the standards of care, like it's standardized. My only problem let me not say the problem. With regards to the standardization, they just use a common language, okay? Then they also have a comprehensive list that you can choose from depending on the patient's situation. Here's the thing, the standardization is just for language purposes only. You must understand that each patient is unique. You are going to create a unique care plan for that patient. What the nursing diagnosis handbook, especially the classification, is just to serve as a guide so you can produce those the appropriate plan. Does that make sense? And also what you'll find is with regards to planning and intervention, you see how they are so close together because your plan is just your thoughts and your intervention is your action. You must understand they usually combine the two anyway. You're going to see that a lot, especially when you get to your med-surg classes, you're going to see planning and intervention combined together. But at this level, you just need to know them separately so it makes sense. Now, this part is what I don't want y'all to play with. Okay? You must know the different types of nursing intervention. That include nurse-initiated versus physician-initiated. It's very simple. Don't overthink it. Nurse-initiated is simply like what it says. This is the nurse doing the intervention, not relying on someone else to give them an order to do that procedure. For example, the patient is uncomfortable. I'm not going to wait 10,000 years for the doctor to call me back and say, turn the patient. Yeah, I better not be calling the doctor for that, number one. Me just going ahead to turn the patient, even every 2 hours, that's nurse initiated. Okay? The patient is in pain. The patient has no medication for pain. The patient needs medication. Now I have to call the physician and get an order for pain. That's a physician-initiated action. Does that make sense? Because I have to rely on a physician to give that medication for pain. I can't go doing what I want to do independently. I cannot act autonomously. Okay? Let's make it also a bit more complicated. The patient turns blue. I use this example a lot. Okay? If the patient turns blue, I'm not going to wait again hours on end for the doctor to give me an order to apply nasal cannula at 2 liters. I'm going to go ahead because, now remember, I said this before, oxygen is medication. Oxygen is medication. However, the patient is in distress. And I noticed that the patient, when I took the pulse ox, the patient's pulse ox is 79% on room air. I will go ahead and apply the oxygen at 2 liters. I just conducted a nurse-initiated intervention. However, when I communicate to the physician and tell them the data using the S-bar report, okay, I need to inform the physician, this is what my data collected, this is how I intervene. Now I'm waiting for further orders from the physician. Go ahead and increase it to 4 liters or get a chest x-ray, etc. I have to wait for the physician's order. That will now become a physician-initiated. Are we cool between physician versus nurse-initiated? Very simple. Don't trip. Okay? Yes.
Okay, I have an example. Let's say the patient's really combative, and you need chemical restraint or whatever, and the doctor isn't messaging you or whatever. How would that work? You can't
do anything until the doctor give you an order for a chemical restraint. Now, if it's a physical restraint where you're putting a wrist restraint and the patient is combative and they are a threat to themselves and others, I'm not going to wait for a doctor's order. I'm going to go ahead, because remember now it's an issue of safety. I'm going to go ahead and restrain the patient, get the patient calm them down, because I can't give any medication or anything like that, but I can apply the physical restraint. Now, once the patient is calm, I'm going to go and notify the physician, let them know, because I have to get an order. But yes, you have conducted a nurse-initiated with regards to the restraint.
The
Put it.
physical restraint.
Huh? The physical restraint. Yes, because it was an emergency situation. Okay? I see your hand. I have another example. When I was working bedside, I was charging a patient, one of my nurses, her patient was going into SVT. Are we familiar with that medical term? What is SVT?
Over 150.
Yes. Okay, the heart rate was just going up, right? This patient was confused. Okay? And the doctor was not calling back. Patient confused, heart rate is going from 100 to 120s, 130s, we don't know what's going on. So what the nurse did, which was very smart of her, by the way, and the patient is confused, she told the patient, hey, act like you gotta poop, I need you to poop, poop, poop. That was nurse initiated, because we can't wait 10,000 years for the doctor to call back before the patient's heart explodes, right? That was nurse initiated. Does that make sense? We can't give medication, but we have to deal with that situation.
How did that help?
Oh, the heart rate went down.
The vagus nerve.
Yes.
Oh, from like
Reverse.
trying.
Yes, from like that act of pushing down, right. That was a nurse initiated move, independent. She didn't wait for anybody, and she resolved that. It was a temporary fix because it wasn't going to help for long. But she had to keep on telling the patient to do that until we got further orders for a medication to actually help stabilize the patient. So you have to know what to do in critical situations. You can't always wait for the physician. You better not always wait for the physician for certain issues. Yes.
So as a nurse, when you initiate intervention, so like you said with the oxygen and what did you say?
Turning the patient.
Right. So after you have to then get an order from the patient after.
Not from the patient, from the doctor.
I'm at the physician.
Yes.
To get the order from the physician.
Depending on the situation. For example, the patient is uncomfortable, like the physical restraint, that warrants a physician order right away.
Right.
Right? Because it also has to be renewed every 24 hours, etc. But it depends on the situation. Like the patient who was uncomfortable in bed or who is at risk for skin integrity issues, I don't need to wait for a doctor's order to turn the patient.
But you need the order still.
No. To turn the patient? No.
Not beforehand, but afterwards.
But I'm saying
You do not.
Like an order.
That they can write it if they want to, but you don't need to wait for a doctor's order to turn a patient who's at risk for skin pressure
No, but
ulcers.
she's saying you already turned them. You already did before, but now you have to go back to
Like
the
for
physician and ask them.
documentation, like do you need a order
After you already.
After I hear what you're saying, no, because I'm gonna keep it 100. The example with turning the patient for a patient who is at risk for developing pressure ulcers. I know for that pressure ulcer not to even develop, I'm gonna turn you and get you up and down, get you up and about just to prevent it. I turn the patient like I'm supposed to. I document it. Am I going to wait after I've turned the patient for a doctor's order to continue? No. You don't have to, but you should bring it to the physician's awareness. Like, listen, this patient is aware. Yeah, you can communicate it. And if the physician feels it's necessary, they'll write an order. But that doesn't stop you from continuing to turn the patient every 2 hours, every 1 to 2 hours.
What about same situation for physical restraint? If you have.
Now, that's different. Physical restraint, you do need to have a physician's order like yesteryear.
But you can do that they're combative, but then
If they're
afterwards.
yes, because it's a matter of safety.
Mm-hmm.
And it's even in your book, in an emergency situation, and this is real life, okay? In an emergency situation, you've tried, and again, remember, restraint is always your last resort. But you tried everything else. You tried talking to them nicely. You tried distraction. You tried this. You tried whatever you could think of. But the patient continues to escalate and get more and more combative. Hey, all right, partner, we're gonna have to, hold you down. So get the restraint, and all of your for documentation purposes and for legal purposes, you need to document everything that you've done prior to the restraint. Why you even have to even apply the restraint in the first place without a physician's order. Okay? And once you've applied that restraint, you kept the patient and others safe. Now I'm on that phone like crazy getting an order to have the restraint kept. Because if not, you're gonna have to remove the restraint. Okay? Or get upper management or whomever involved. Yes.
So, under our licensing and autonomy of a nurse, the nursing interventions that we come up with fall under our nursing diagnoses, do those generally not need doctor's orders, like because that's under our scope of practice?
No, it depends on the intervention.
Okay.
For example, pain medication, and your plan is to administer the pain medication. So what you're going to put under the implementation, administer pain medication as per MD order.
Right.
Because that shows that you completed a task that required the physician's order. Okay, you're not doing it because of intuition or instincts. Okay, good question. Are we cool? All right, very good. All right, so now here's another thing too with regards to physician-initiated interventions or physician orders. You must understand, as the great fantabulous nurses that each and every one of you are going to be, it's not every order that the doctor prescribes that you are going to execute because the doctor ordered it. Let me say this again. It is not every order that the physician prescribes in the patient's chart that you are going to execute. You need to learn how to question certain orders, or when not to even execute those orders. Let's say the patient was combative and then there was an order for Ativan, which is a sedative, right? Cool beans, you gave the sedative, patient is calm. Okay, and the doctor orders that sedative around the clock, every 4 hours, not even as needed, but every 4 hours. If the patient, you come to the room, is knocked out, but they're still arousable, am I going to go ahead and give that sedative? No, you're not going to say because the doctor said so, or because the doctor ordered it every 4 hours is the reason why I'm going to administer that medication. Cool? So you need to learn to question those orders, physician orders, yes.
Do you document that?
Yes, you must definitely document. Why didn't I give the sedative at this prescribed time, at the set time? Patient is relaxed, patient is sleepy, patient is non-combative or whatnot, okay? Let's say, for example, the physician ordered, this goes back to now your ethical principles. Remember the non-maleficence? Okay, the patient has a potassium level of 6. Doctor orders potassium. Am I going to even execute it because the doctor ordered it? No, I'm going to call that physician and be like, hey, doc, listen, I noticed you ordered potassium for this client in room such and such. Their potassium is 6.0 currently, and you ordered potassium 5.0. Recommendation, do you want to, instead of potassium, order K-oxalate, something that could help eliminate the potassium levels because the patient's potassium level is high. Does that make sense? Don't be afraid to question these doctors' orders.
Because they don't call you or anything. They don't correct anything.
Look, they will call you. We have some good doctors. Let's not bash all our doctors. If it's not the primary physician, they usually have somebody on call. They should have somebody on call to respond for
You
them.
have to discharge some orders, right? You have to call and be like, hey, this one.
Yeah. If it's not an emergency, if it can wait, it waits. Or you just call and put your notes in, but as long as you did your part. Now, that is true. Some physicians do not call back. And you have to understand, it's not because they don't want to most of the time. A lot of times it's because the physicians has hundreds of patients between hospitals. Like in this hospital, they got 100 patients to go see. In that hospital, they may have 50 patients to go see. In another hospital. So it's going to be a minute. Okay? But you still have to make sure you do your part in providing safe quality care. Okay? And maybe hopefully they have an assistant that's working with them so you can get things done. All right, but you definitely have to document. Okay, nursing interventions for various problems. Again, for actual nursing diagnosis, your interventions should serve the purpose of reducing or eliminating contributing factors. It has to promote higher level wellness and monitor and evaluate the status. Okay, that's the purpose of intervention for actual nursing diagnosis. Does that make sense? So in other words, your interventions are going to be according to the type of nursing diagnosis. The problem is to make sure we reduce or eliminate that issue from happening in the first place. Like we said earlier, the patient, y'all saw me with Nate saw me with walking all funny, like I was ready to, fall, but I did not fall. his intervention is going to now be something that is tailored to me not falling, to prevent me from falling. He's probably going to reorient me. For example, his interventions may say reorient the patient back to the room, or educate the patient on the importance of staying in bed, or using the call light. Educate the use of the call light. It's going to be, you can have an unlimited amount of nursing interventions for that one nursing diagnosis. Okay? Then you have, for collaborative problems, your intervention is going to make sure you monitor for changes. It also serves the purposes of making sure you monitor and manage the changes with that is nurse prescribed versus provider prescribed, okay? And then of course we evaluate those changes as well. Evaluation, again, we said it's a type of assessment that is basically looking at if your goals were met or not met, and what changes that needs to be taking place in order for them to be met. Here's an example. Did the patient's pain level decrease as expected? If it did decrease like you wanted it to, it went and within the time frame that you expected it to, you ain't got nothing else to do. We move on with life. Document and keep it moving. But if the pain level did not decrease after giving pain medication, now we're going to go back to the drawing board. Okay. Where's your pain now? What makes it worse? You're going to ask other questions, etc. And then I give this example of where after one shift, the nurse finds the patient's pain level decreased to 2, indicating it was successful. If the goals wasn't met, again, the nurse would have reassessed the care plan. Now, with regards to your eval, these are the classic elements that has to be included in your evaluation, especially when you're doing your care plan. You got to have your clinical instructors like, damn, they know what they're doing, okay? You're going to be teaching them what's up, all right? You're going to identify the criteria and the standards. What were you looking for in the first place? Whenever you come up with your evaluation, you got to think of what's the end goal, okay? Patients in pain, that's what I've identified in my data collection or assessment. My pain medication, I keep telling y'all, don't just do interventions. You need to know why it is that you are doing what you are doing. What's the purpose of me giving this pain medication? The purpose of me giving this pain medications is for the patient's pain to decrease or eradicated as much as possible, right? That's the expected outcome. So you collect data to determine whether those criteria were met, and you interpret those findings, okay? So I collected data. This is not in my evaluation phase. I collected data, and the data revealed that, yeah, the pain medication did work. My goals were met. Or the medication did not work, my goals were not met, so now I'm going to collect further data, right? That's my interpretation, and then I document, and then I either terminate or continue or modify the care plan. Once you are doing your care plan, you're going to find at the end for the evaluation, if your goals were met, you terminate that aspect and you either continue with other issues or discharge the patient, depending. Or you can continue, depending on what is going on, or you can make changes as necessary, okay? Your statements, basically, what you're gonna say to make sure is you know what you're talking about. You're gonna say, for example, beginning 6/8/2025, the patient will ambulate half the length of the hallway with assistance 3 times daily. Okay, that was the goal. Statement. That was the goal you were looking for. All right. And then your evaluation statement will say the goal was partially met, and you're going to say why it was met, partially met, or not met at all. Patient refused to ambulate in the morning, but did walk to the bathroom once in the afternoon. This is what your evaluation goals is going to look like in terms of your statement. All right. Then you have this performance improvement. It has 4 steps. You identify the problem, plan, implement, and then you assess if there's any changes. That's basically the nursing process under performance improvement. And then quality assurance, because you are BSN students, I gotta teach this to you guys because you're going into management maybe. Quality assurance has 7 steps, okay? And this all is for the purpose of making sure you improve the outcomes of your client, okay? Your client care. Identify, again, this is the nursing process all over again. You're identifying the values, identifying the structure, measure the degree of the attainment, you make your interpretation based on what you've identified, and you identify possible course of action. This is your planning, and then you choose your appropriate course of action, which is still your planning, and then you take action. That's your intervention. And that's really the nursing process. See, 6 chapters. That's it. Nursing process.